Hello students, welcome. Myself Dr. Roshini, your OBGYN faculty at DigiNerve. As we have now completed INI-CET exams, let us do a quick recall of this INI-CET exams. I know you're all very much relieved of the exam is over, but be even more confident now that all these questions were what we have asked and it was basics and it was all that we have taught. The only things that we told to concentrate on basics and emergency, these are the only questions they have given you. There is no single question beyond what we have taught for you. Okay, I am very sure you're all successfully finished this exam. So let us check if your answers are correct. Hope for the best. So to begin with the first question, a pregnant woman with placenta previa presents with mild bleeding. There is no uterine contractions and her blood pressure is 110/70, that is normal, and fetal heart rate is 140 beats per minute, that is also normal. What is the best next step of management? Okay, she's had mild bleeding. Okay, this is what the complaints are: mild bleeding, BP is normal, that means she is stable, fetal heart rate is normal, that means baby is stable. Then what you'll do next? What is that? McAfee Johnson's regimen. What we told, if everything is fine, we want to continue till term. Though they have not given us the term gestation, what is the period of gestation, but whatever it's said and done, we are going to carry it her till term, isn't it? At least 37-38 weeks. So ARM, there is no need to induce labor for her. So we are not going to give oxytocin or ARM for her, or oxytocin induction of labor is also not going to be done for her, because in placenta previa, the mode of delivery is always cesarean section. There is no role of normal delivery. So neither ARM or oxytocin is going to be done for her. They are absolutely wrong. So you are not going to choose that anyways. Hospitalization and expected management, or immediate lower segment cesarean section. Since everything is normal, we are not going to terminate her immediately. So the best correct answer will be your hospitalization and management. In our recent INI-CET quick recall or revision class that we had done for you, in that I had given a same question for you. You can see this: a 28-year-old woman, she is stable, fetal heart rates are reassuring. So what do we do? Expected management with hospitalization and close monitoring of bleeding. This is what we had chosen. The same question was asked just 2 weeks before the quick or most important topic MCQ recalls in which we had done. So the correct answer is C. I'm sure you've all answered this. So going ahead with the next question. A 36 weeks pregnant woman is being evaluated for possible eclampsia. What is the following symptoms are not indicative of imminent eclampsia? This question also in that same webinar that we did, the important topic MCQ revision, we have done the same question again. Headache, blurring of vision, epigastric pain. All these three are features of imminent eclampsia. So pedal edema. Pedal edema is not there. Even with 140/90, no signs they can have pedal edema. In fact, physiologically also patient can have pedal edema. I'm sure this much common sense, though you're tensed in your exam, you would have definitely used it and chosen the correct answer. That is your pedal edema. That is not a feature of imminent eclampsia. So as we had discussed, we had told, concentrate on basics and emergencies. How will you handle? So first two questions also are the same topic, APH, which we told repeatedly is one of the important topics. See, the same question we had asked: BP is more severe eclampsia, imminent eclampsia features we had given here. Headache. I even had told you the imminent eclampsia like headache, blurring of vision, and epigastric pain. So the same thing we had told for you also. I'll attach the link of the webinar that we had done, recalls. So you can see most of the questions were from there. Okay, most of it, almost 50% above the questions were from there. If you had attended that 1 hour of webinar, it would have been so much useful for you. Yes, the correct answer is D, where we will do, where the pedal edema is not a feature of imminent eclampsia. Going ahead with the next question. Which of the following instruments are commonly used during cesarean section? This you will definitely answer if you have attended at least one cesarean urine internship. You have seen the instruments, you have learned the instruments, isn't it? So green armitage, where do we use green armitage? At the angles. If this is the uterus, this is the incision that you have given, or this is the incision that you have given from here. The angles is what you put as a green armitage. Or when there are major vessels bleeding, there you'll put a green armitage. The flat instrument at the tip. Okay, this is what you'll put there. Shirodkar's clamp. Do we use it in cesarean? No, we use it in hysterectomies and myomectomies. This is a wrong answer. Doyne's retractor. With what do you pull the bladder down or away from the incision site? You use Doyne's retractor to pull, isn't it? So this is also there. This is also used in cesarean section. Scalpel and BP holder. This is used in every operation. So this cannot be missed at all. Alice forceps. How do you hold the uterine segment, the upper and lower segment? With what do you hold? You hold it with Alice forceps, isn't it? So Alice forceps is again the correct answer. So Cuscos and Carmen's. Where do you use Cuscos and Carmen speculum? Cusco speculum and Carmen's suction evacuation for abortions. This is where you use Cuscos and Carmen. So this is a wrong answer. So correct answer is your A, C, D and E. Which is it? A, C, D and E. So this is your correct answer. Answer C. So, as we have told in cesarean section steps, we have given a clean video of a cesarean section also showing all the instruments. Okay, so you can see that and you can definitely be able to answer this question. Next question. A 45-year-old postmenopausal woman has an endometrial thickness of 15 mm on transvaginal ultrasound. What should be the next best treatment? So this topic almost maybe in every 3 days once you would have been listening in one of the reels, or so many times we have showed you this video. Yes, postmenopausal bleeding or abnormal uterine bleeding or an intermenstrual bleeding, for everything you have to evaluate by doing a biopsy. Okay, so here for a postmenopausal patient, what is the normal ET thickness? What should be there? Yes, it is less than 4 mm. Anything more than that should go for evaluation, isn't it? So what is the next best management? MRI pelvis? No, you have to have a tissue biopsy confirmation. So in that you won't have a tissue biopsy confirmation. Hysterectomy, directly can you go for hysterectomy? What if it is a CA? You cannot do, isn't it? So this is also wrong answer. Endometrial biopsy. So this is your correct answer. Repeat vaginal ultrasound after 6 weeks. So you will miss, or the disease will get progressed for next 6 weeks. So you cannot wait for 6 weeks. In fact, I even had told you what is the ideal or gold standard method for such case. How do you want to do endometrial biopsy? Is by doing a hysteroscopic guided biopsy. That is the gold standard, isn't it? So whatever said and done, the answer is biopsy. You have to do a biopsy. So this also in the same class we had done a revision. What is the best thing? USG you will do. On that, if the ET is postmenopausal patient, USG will do. If the ET is less than 4 mm, you will leave her alone. If it is more than 4 mm, you will go for endometrial sampling. Best would be your hysteroscopy guided biopsy. I am sure you would have answered this question 100%. Next, this is one of the important things. I have given you the same figure and asked you the question. Same figure. Identify the condition based on the image provided. What is this? This is a strawberry vagina. See, I have told you Trichomoniasis vaginalis is strawberry vagina. So I had given the same. What is this? How do you treat? This is what I had asked, in which I had explained what is this? A strawberry vagina, Trichomoniasis vaginalis. So here they have asked what is the diagnosis. So it is Trichomoniasis. Correct, isn't it? So how do you treat it? What is the treatment of choice? Yes, in this question you answer me now. Yes, treatment of choice is metronidazole. Correct. Next question. Which of the following does not indicate a syndromic approach of sexually transmitted infections? So STDs, we give kit 1, 2, 3, 4, 5, 6, isn't it? In the STD class that I have taken, I have given a detailed description of which discharge or which swelling or which painful ulcer is there, which kit is used. So which is the basic category for telling it as where you will need a syndromic management? What are the 4 categories? This also we had taught for you. What is it? Urethral discharge or vaginal discharge. Be it for a male or female, it is mostly for females we had discussed. It is the same. Urethral discharge in men, urethral and vaginal discharge in female. Correct. Inguinal swelling or the lymphadenitis. Abdominal pain, yes. Lower abdominal pain, as such, we have not specified. It is just the abdominal pain. And one more thing is there. What is that? Ulcers. Okay, these four reasons where we start is the syndromic management kits. Okay, so the correct answer here would be a lower abdominal pain. But I'm not sure if it was answer was lower abdominal pain or something else was given. This is what the recall that we have got. So we have chosen that option. So, see, we have told you for whom all we start this syndromic management, vaginal discharge or urethral discharge, like in bacterial vaginosis, candidiasis, trichomoniasis, genital ulcers, like in syphilis, cancroid, lymphogranulovenereum, herpes, and in pain abdomen, in gonococcal, chlamydial, and anaerobes, multibacterial, in polymicrobial infections, lymphadenitis, like in lymphogranulovenereum, GI, and cancroid syndromes. Okay, so these are the basic four categories where we have classified and added the different kits for that. Next question. Postpartum intrauterine contraceptive device insertion should ideally be performed within which of the following time frames? Okay, see, here one important word has been added, ideally. Okay, it can be performed until 48 hours of postpartum. That means for 2 days you can still insert, but 24 to 48 hours chance of expulsion is very high, but still you can do it. But ideally, when do you do it? Immediately after placental separation, that is within 10 minutes of placental separation. This is one of the confusing question, because most of the time what we have told you is we can do it up to 48 hours, 24 to 48 hours postpartum. This is what we have told, because it is not ideal, but you still can do 24 to 48 hours postpartum. It can be done. So this is a correct answer, but this is not ideal. In ideal situation, you should put within 10 minutes of placental delivery. Okay, so this will be the correct answer. After 4 weeks, there is nothing like that. After 6 weeks, yes, after 6 weeks also you can put a PPIUCD, but that time it doesn't become a postpartum IUCD. It doesn't become a postpartum IUCD insertion. It becomes a interval IUCD. So that is after delivery, after 2 months or after 2 years you put, that becomes a interval IUCD. Immediate postpartum or PPIUCDs are within 10 minutes of placental delivery till 48 hours of delivery. Ideally it is put within 10 minutes of delivery. Okay, going ahead with the next question. A patient presents with intermenstrual bleeding, the pap smear report shows atypical glandular cells. Okay, atypical glandular cells. What is the most appropriate next management? Okay, first thing first, it is a intermenstrual bleeding. Okay, you have to evaluate both cervix and vagina. What is the most common cause for intermenstrual bleeding? It is polyps. Okay, polyps, intrauterine or cervical polyps. Okay, that, and whenever it gets infected, it becomes more chance for intermenstrual bleeding. Okay, so now there is intermenstrual bleeding and pap is abnormal. Whenever there is a glandular abnormality, what we have told you, where is the abnormality? Whenever there is a glandular abnormality, it becomes a endocervical region abnormality. So there is endocervical abnormality. So now you have to curate it and see. So first, for the cervix correct visualization, what can you do? You can do a colposcopy to see the visualize the cervix clearly. 20 times magnification is there in colposcopy, isn't it? 20x magnification, and you can put color also and see for abnormal cells, and you can put acetic acid or Lugol's iodine also and see. Plus, since there is intermenstrual bleeding, you also have to evaluate the endometrial cavity, for which you will do endometrial biopsy or sampling. So, colposcopy and endometrial sampling both has to be done in this patient. So, let us see what is the correct answer they have given. Hysterectomy. Can you directly go ahead? Never. So, always tissue biopsy confirmation is required. No, this is not the correct answer. Conization of the cervix. That time you can only evaluate the cervix. You will be left out with the biopsy, and this conization is not correct. Maybe if she still has to complete, then she will end up having a cervical incompetence. So before going for conization also, you need a tissue biopsy. So this is also wrong. Repeat pap smear after 6 months. Remember, glandular abnormalities are always severe and has to be considered as urgent, because if you leave, they progress faster. You cannot wait for 6 months. Colposcopy and endometrial sampling. Yes, colposcopy, you can see the pap smear abnormality. Endometrial sampling, you can see why the intermenstrual bleeding is there. So both of them can be done. Yes, both of them has to be done in fact. So the correct answer is D. Next question, which of the following is not a test? Okay, not a test for ovarian reserve during early follicular phase. Okay, all of these may be a test for ovarian reserve, isn't it? Estrogen, yes. FSH, yes. AMH, yes. Antral follicle count, yes. All of them are a ovarian reserve test. But which of them is specific for the early follicular phase? Early follicular phase means where you do on day 2 or day 3 of cycle. If ever in your infertility OPD you have been sitting, you must have been noticed on immediately on day 2 of cycle you get these investigation and come. So those investigations are what? Estrogens and FSH, and you will do a scan to see the follicle count. But remember, this we have told multiple times before also, AMH is not cycle related. It can be done any time of the day and any time of the month. But FSH and estrogen are always done on day 2 or day 3 of cycle. This we have told before also. See, you can see basal day 3 FSH should be done, and day 3 estradiol should be done. AMH can be done in any time of the month. Antral follicle count, yes, antral follicle count can be done. Yes, antral follicle count is usually done on day 3 of the cycle and then kept on monitoring to see which follicle is going increasing in size, which follicle is becoming dominant. So on the day 3 of cycle, you can get a basic idea of the follicle count. So you do on day 3 of cycle. So the estrogen, FSH and antral follicle are done on day 3 or early follicular phase, but not AMH. AMH is not cycle or month dependent. Next question, which of the following statements about shock is accurate? So shock we have discussed in multiple parts. Yes, we have discussed this, but in multiple parts. So they have combined it to one and given it to you. Gram-positive bacteria causes endotoxic shock. Is it? No, gram-negative bacteria. The lipopolysaccharides around the gram-negative bacteria will release the endotoxins, causing endotoxic shock. So it is not gram-positive, it is gram-negative. This is wrong. So what is accurate has been asked. Uterine inversion in the postpartum period causes neurogenic shock. Yes, this also we have discussed, isn't it? Why it causes like that? It stimulates vasovagal nerve. Whenever there is sudden uterine inversion, there is vasovagal nerve stimulation and then causing vasovagal reflux and causing bradycardia, hypotension and shock. Okay, that is a neurogenic shock. Later date, it can start bleeding and cause hypovolumic shock also. But ideally, it is following a uterine inversion, it is a neurogenic shock. Okay, so this is a correct answer. It is accurate. Severe shock occurs with more than 20% of blood loss. Is it? Not more than 20%. 15% is mild, moderate is 20 and 30, up till 15 to 30%. Anything above 30 to 40% is considered severe. If it is more than 50%, that is life threatening. Okay, so 15% is mild, 15 to 30% is moderate, 30 to 50 is severe, more than 50 is life threatening. Okay, this is what you should know. So this is wrong answer. Hypoperfusion with increased cardiac output. Whenever there is hypoperfusion, do we have increased cardiac output or decreased? Yes, it is decreased cardiac output, except in one case. Where do we have hypoperfusion but there is tachycardia? In septic shock. Since it is generally telling, we are excluded, and hypoperfusion is usually associated with hypotension and low cardiac output, not increased output. Hypoperfusion with increased output or increased heart rate is seen only in septic abortion or septic shocks. Last question. A primigravida with normal vaginal delivery develops postpartum hemorrhage. Okay, PPH. This also is one of the important topics and we have done a recent recalls for INI-CET also. Not controlled by uterine massage. Okay, how do you manage PPH? First is medical management, then is your mechanical management, then is your surgical management, and last would be your hysterectomy, isn't it? So uterine massage, what should be your next step in the management? Hysterectomy, can you go directly, miss all these things and go for hysterectomy? No, this is definitely not the choice. Balloon tamponade. So uterine massage is a mechanical method. So next method will be in mechanical will be your balloon tamponade. So this will be your correct answer. Uterine artery embolization. Embolization is not frequently performed. Before that, we have many other surgical methods. We can do V-Lynch, we can do Heyman suture, we can do many other stepwise devascularization. Embolization is nothing in easy, and for that you should be pre-prepared. It cannot be happening on an emergency basis. So as in cases with placenta previa where you are expecting severe bleeding, you can be ready with uterine artery embolization and go ahead with the procedure, but not ideally done in case of emergencies. So here what you should do is a stepwise devascularization, not embolization. Pelvis specific embolization, I really do not know what this option is, but I'm sure your next answer, best management, is balloon tamponade. This also we have discussed in our recent topic. Coming first were the medical methods that we had discussed in detail. Then we discussed about the mechanical methods, uterine massage, bimanual uterine compression, and uterine tamponade, balloon tamponade. And then would be your surgical management, like your uterine artery ligation, your ovarian uterine artery anastomosis, internal iliac artery ligation, or you can go with Belin sutures, Heyman sutures. If nothing of these works out, then we will go ahead with the hysterectomy, isn't it? I'm sure you've answered all these questions correctly. I hope we have helped you a lot for your exams. Please give us a review of how you have learned and how you have done your exams. If you have any doubts for any questions, please feel free to ask to us. Thank you. Good night. All the best.